So percutaneous transcatheter mitral valve repair is the predominant transcatheter option for the treatment of non-rheumatic MR in US and most countries. If I came 10 years ago, I wouldn't be able to say that sentence. Repair, if possible, is preferable to replacement. Mike, you agree with that, right? And mitral transcatheter edge-to-edge repair is the only FDA-approved device for selected patients, and trials are ongoing to expand indication. So where are we here now? This year is a very important year. This was exactly 20 years ago when the first patient was done, June 2003. She was a nurse, and she underwent a mitral clip procedure, single clip. She was 56 years old, and she actually died only 2 years ago from COVID. She otherwise did well with this one clip. There are now over 200,000 cases done worldwide, and the FDA, as you know, has approved it for high-risk primary MR and also for secondary MR, which we're going to talk about. It's been safe from very beginning. It's been effective in selected patients. I use the word selected patients. It's been durable, but mostly for high-risk patients. And there are ongoing clinical trials considering for moderate risk. This, as you know, translated into mortality benefits. And the absolute reduction of mortality at 24 months is 17%. There are very few things that we do which has an absolute reduction in mortality of 17%. That means you have to treat 6 patients to save 1. I don't think any of the drugs that you use in heart failure have that magnitude of benefit. And you can see those lines have remained parallel, again, because of the crossover that took place at 24 months. If the crossover did not take place, it probably would have been even worse. So this landmark study led to, of course, the approval for functional MR and indication. And it is indicated in the United States for functional MR who are severe functional MR in spite of medical treatment and irrespective of the surgical risk. This is very important. It's irrespective of the surgical risk, it will be the considered treatment. So based on the collection of data, based on the collection of treatment, these are the present guidelines. And for fellows, this is what you need to know. It is approved for patients with severe symptomatic primary MR who are at prohibitive or high surgical risk and who have a reasonable anatomy which is suitable, and the patient has to have a life expectancy of 1 year. So it's really a very small population patient for primary MR. When it comes to secondary MR, it's approved for patients with chronic severe MR who have still MR in spite of adequate guideline-directed medical treatment. Now, what people will say to you and criticize us and say, wait a second, but not many people in that trial had Entresto being used. Not many people had SGLT2 used. And what would have happened if you had all these drugs? Would the trial still be positive? And I get this question every time. But the thing is that what would have happened probably is that the number of patients that we would have got at any point would have been less because some would have been more adequately treated. But both of the arms were equally treated, right? So for those patients who had severe MR in spite of this medical treatment would be in the same problem. So it's not that it would change because in this study, it was adequate medical treatment plus clip is better than just adequate treatment alone. With that and going in this platform, our next thing is what do we have going forward? So we have randomized trials comparing MitraClip to transcatheter valve replacement. What if TMVR becomes very successful? Will TMVR be as good or better? And you have the SUMMIT trial, which is randomizing MitraClip to 10-9. And as expected, this trial is not enrolling very well because it's difficult to enroll these patients. The second is there are going to be other platforms on TMVR, which will hopefully randomize to MitraClip. And then finally, most important, which I'm interested in, is expansion of indications for patients with moderate surgical risk. So let's understand surgical risk. If you look at surgical risk, if you consider low-risk surgical mitral, it should be less than 1%. The frailty, there should be no frailty and there should be minimal cardiovascular abnormalities, for that's a low-risk patient. Okay, that's fine. Then also in the definition is the high-risk group of patients, which have to be 8% or 6 to 8% mortality risk. So you have one side 6 to 8%, the other side you have 1%. So what is in this big group in between, 1 to 8%? What about these patients? probably these are the moderate risk patients. I'm sure there are patients in this category. So what do we do for these patients? At the moment, we can offer them surgery, but maybe a clip would be a reasonable thing too. So I want to summarize with these two cases that the treatment of MR or mitral valve disease is very complex. There is a role of surgery, of course, that is the standard of care. And there's also going to be a role for transcatheter therapies. There's a role for repair as well as replacement, because this is unlike other tools, there's going to be a role for both. And there's ongoing clinical trials evaluating the role of repair for moderate surgical risk patients.